Okay, it's 1 minute past the hour. I think we're going to get started. Welcome to this webinar on the timely topic of venous thromboembolism and COVID-19, the latest evidence and prevention strategies. My name is Bill Nadeau, and I am the Global Director for Medical Affairs at Cardinal Health. I'm delighted to welcome Dr. Salma Batool-Anwar to deliver this presentation on VTE and COVID-19. Dr. Batool is an instructor at Harvard Medical School and an associate physician at Brigham and Women's Hospital. She received her Doctor of Medicine from Rawalpindi Medical College in Pakistan and her Master's in Public Health from the Dartmouth Institute for Healthcare Policy and Clinical Effectiveness. She's trained in internal medicine, pulmonary critical care, and sleep medicine. Dr. Batool is a clinician scientist interested in a variety of research areas, including the epidemiology of sleep medicine and quality improvement in healthcare. She's involved in undergraduate, house staff, and fellows teaching, both from a didactic as well as from a case-based approach. Dr. Batool holds multiple administrative leadership positions and serves on numerous local Boston area committees. She's passionate about the prevention of VTE and has been working in Boston throughout the COVID-19 pandemic. I am honored to welcome Dr. Salma Batool-Anwar to deliver this presentation on VTE and COVID-19, the latest evidence and prevention strategies. Please go ahead, Dr. Batool.
Hi, Bill. Thank you so much for this introduction, and thank you for providing me with this opportunity to discuss this very important topic on COVID and thromboembolism. During this talk, I will discuss briefly the disease burden, clinical manifestation, its effects on coagulation, and with prevalence of thromboembolism. And finally, I'll present latest evidence on COVID coagulopathy and guidelines from experts on management. This is my disclosure here. Over the past several months, severe acute respiratory syndrome has overwhelmed the healthcare system, causing global healthcare crisis and significant mortality. And this is the third coronavirus-related respiratory illness after SARS and MERS that we have seen in the past couple of decades. As far as the timeline for this COVID goes, it initially started in Wuhan, China in late December 2019 as a series of pneumonia of unknown etiology. And within a month, a novel beta coronavirus was identified as the causative agent for acute respiratory syndrome. Shortly after, the World Health Organization named the disease as COVID-19, and it was officially declared a pandemic in March of this year. As of June 1st, the WHO has reported over 6 million cases and over 300 deaths from COVID-19. Unfortunately, there is no global or standard response to this pandemic, and each country is dealing with this crisis differently. SARS-CoV-2 has been found to have higher levels of transmissibility, and average incubation period is estimated to be ranging from 2 to 14 days. Complete clinical presentation is not yet clear as symptoms range from mild to severe or even in death. SARS-CoV-2 predominantly targets the respiratory epithelium, causing severe respiratory failure and the need for mechanical ventilation and ICU care. Period from the onset of symptoms to death range from 6 to 41 days with a median of 14 days. The viral infection triggers a complex host response in which both pro-inflammatory and anti-inflammatory mechanisms play a role, resulting in either clearance of infection and tissue recovery or to organ injury from cytokine storm, which is basically a hyperinflammatory state characterized by elevated cytokine levels and eventually causing multi-organ dysfunction. This immune reaction depends on patients' conditions and other comorbidities. Several studies have reported hypercoagulability and very high prevalence of thromboembolic events among patients with COVID-19. Before we talk about COVID coagulopathy, let's just briefly discuss coagulation and thromboembolism. Venous thromboembolism is a major public health issue with increasing hospital admission rates, and a significant portion of hospitalized patients develop venous thromboembolism. DVT-PE are the third most common cardiovascular diagnoses after coronary syndrome and stroke, and have increased mortality and morbidity. An estimated incidence of 1 per 1,000 persons has been reported, and 1 week survival rate after pulmonary embolism has been reported as only 71%. Although life-threatening, the venous thromboembolic condition remain unrecognized even in modern healthcare system, and PE remains a serious cause of mortality in both surgical and non-surgical patients. Most pulmonary embolism are associated with deep vein thrombosis, and unfortunately, sometimes death is the first presentation of pulmonary embolism. A 5-year retrospective study of all autopsies reported that 25% of all PE present as sudden death. Independent risk factors for venous thromboembolism include advanced age, obesity, mobility, pregnancy, and additional factors are cancer, congestive heart failure, and prior history of pulmonary embolism or DVT. For critically ill patients, hypotension, sepsis, and respiratory failure are additional risk factors for thromboembolism. The prevalence of venous thromboembolism is inconsistent across all groups of medical patients. Studies investigating the risk of venous thromboembolism have found that infectious diseases, heart failure, or respiratory condition are among the most common conditions at admission. According to the International Medical Prevention Registry of Thromboembolism Trial, or the IMPROVE trial, 32% of patients had infections, 19% had respiratory failure, and 11% had congestive heart failure. MEDNOX, or medical patients with enoxaparin trial, another multi-center randomized double-blinded study, found that acute infection was an independent risk factor for developing thrombotic complication with odds of over 1.7. This is a hypothetical model of coagulation cascade. The normal coagulation is a balance between procoagulants and naturally occurring anticoagulants. The hemostasis is basically two-step. One is a primary hemostasis when platelets clump together and stop bleeding, and the secondary hemostasis where a series of enzymes-mediated activations of clotting factors happen. Tissue factor, which is located on the subendothelium, is the main initiator of coagulation cascade through its activity for factor 7. And the complex of tissue factor and factor 7 induce thrombin, which is the central product right here, thrombin, which is the central product of an interconnected set of simultaneously occurring events, and participates in multiple positive feedback loops, activating several clotting factors. And all these events set the stage for producing large bursts of thrombin, which is responsible for the formation of fibrin by conversion from fibrinogen. Nature has provided us with mechanism to control excessive clotting. and this coagulation is regulated by inhibitory mechanisms. The circulatory inhibitors of coagulation include antithrombin, heparin, cofactor 2, protein C, and protein S. In addition, endothelial-bound heparin sulfate and thrombomodulin facilitate the inhibitory activity of antithrombin and protein C. And the final step in this regulation is the fibrinolysis, which is initiated by tissue plasminogen activator and hydrolyzes the fibrin strands into soluble fibrin degradation product, or the FDP. It is well known that acute inflammation, whether bacterial or viral, can result in activation of coagulation system. What happens with viral infection is that the coagulation system is activated and several procoagulant markers are elevated. Simultaneously, there's depression of inhibitory mechanism as indicated by decreased level of protein C and S. So on one hand, the anticoagulants are decreased, and on the other hand, there's upregulation of plasminogen activator inhibitor, and thus decreasing the breakdown of fibrin clots. Several viral infections have been linked with hypercoagulable state and thrombosis. In 2009, CDC published a report on 10 patients with H1N1 infection, and they found that over half of the patients had pulmonary embolism and 90% had multi-organ dysfunction. Similarly, higher prevalence of antiphospholipid antibodies and thrombotic complications have been reported among patients with hepatitis C and B, which is evident here in this meta-analysis from 2015, that hepatitis was found to be significantly associated with anticardiolipin antibody positivity with odds of over 11. And here, when they compared the patients with negative anticardiolipin antibodies, a higher prevalence of thrombotic events was seen among patients with positive anticardiolipin antibodies, odds of over 3. Similarly, there's another study on Zika and chikungunya patients where researchers recruited 172 patients and measured their D-dimer levels. And they found that 19% of patients with Zika and 63% of patients with chikungunya had elevated levels of D-dimer. So now that we have established the effects of viral infection on coagulation cascade, let's turn our focus to coagulation in COVID-19. The mechanism of hypercoagulability among COVID-19 patients is likely multifactorial. It has been suggested that COVID lungs exhibit all 3 components of Warsaw triad. High levels of pro-inflammatory cytokines trigger the hypercoagulable state. There is evidence of endothelial injury by elevated WF levels, or the factor 8 levels. Finally, patients with severe respiratory distress who are on mechanical ventilation and are treated with ARDS protocol, they get volume conservation therapy and high PEEP. With these 2 processes lead to decrease in pulmonary blood flow, causing stasis and microthrombi. The patients have elevated levels of fibrinogen and elevated levels of D-dimer. Several studies have shown that critically ill patients have patients with COVID have higher levels of D-dimer. The median D-dimer level 10 times higher than the upper limit of normal has been reported, and it correlates with poor prognosis. Studies have also shown that patients affected not only have DVT and PE, but are also at increased risk of arterial thrombosis and clotting in the extracorporeal circuit. Although now we know that the COVID-19 patients have high prevalence of thrombotic events, there are still no rigorous data on the exact number of exact prevalence of VTE among these patients, and it is possible that the incidence of thrombotic complication is underestimated. because either of their patients' severity that they're unable to get diagnostic testing, or due to lack of services available in certain part of the world. So in this multi-center prospective study, the researchers compared 150 patients with ARDS with COVID-19 to a historic non-COVID ARDS cohort. And they found that 64 clinically relevant thrombotic complications during ICU stay among these patients, and majority of them were pulmonary embolism. When they compared to non-COVID cohort, more thrombotic complications were seen among the COVID-19 cohort. And interestingly, these complications occurred despite thromboprophylaxis. And all these patients at baseline had elevated D-dimer and fibrinogen levels. Several other studies have also demonstrated increased prevalence of VTE among COVID-19 patients admitted to intensive care units. This study from China reported higher incidence of VTE of 25% where they looked at 81 ICU patients with COVID-related pneumonia. Another study from France screened patients treated either with prophylactic or therapeutic anticoagulation and found an overall rate of VTE of 69%. Researchers have also looked at autopsies on patients with COVID-19 reported death, and they have seen frequent venous and arterial thrombosis. This was a study from Germany. Autopsy reports performed on 12 consecutive COVID-19 positive deaths. The sample size was small and mean age was 73, majority were men. Other comorbidities among these patients were coronary artery disease and chronic obstructive lung disease. And over half of those deaths, DVT was not suspected prior to death, and death was attributed to pulmonary embolism in 4 patients. These are just gross findings on autopsy with pulmonary embolism showing here this is the pulmonary embolism, and here you can see the deep vein thrombosis. All these patients had higher concentration of SARS RNA in major organs other than lungs. They had liver and kidney and heart also had elevated concentrations of SARS RNA. Another study was performed on pulmonary autopsy specimens where researchers analyzed 7 patients who died from respiratory failure caused by this COVID-19. And these specimens were compared with lungs from 7 patients who had died from pneumonia caused by influenza A virus H1N1 type, the strain that caused the 2009 and 1918 influenza pandemic. The lung specimen from the influenza were the archived tissue from 2009 pandemic. And what they found that all the lung specimen for COVID group had diffuse alveolar hemorrhage and intra-alveolar fibrin deposition. Both groups, the COVID and the non-COVID specimens, had common morphology of diffuse alveolar damage, but there were 3 distinctive features. Severe endothelial injury was seen among patients with COVID-19. The COVID lungs had widespread vascular thrombosis with microangiopathy and occlusion of alveolar capillaries. And COVID lungs had significant new vessel growth thought to be secondary to great degree of endothelialitis and thrombosis. And here you can see the microthrombi and multiple fibrinous microthrombi in the alveolar capillaries as shown here by the arrows. And this was most recently published in New England Journal of Medicine. So So now that there's mounting evidence of hypercoagulability and thrombosis among COVID-19, the optimal intensity and duration of thromboprophylaxis remain uncertain. However, the scientific and the standardization committee of ISTH and other experts have provided guidance for the management of venous thromboembolism. These guidelines are based on evolving data and consensus. And according to these guidelines, all critically ill patients should receive venous thromboembolic prophylaxis, preferably from a low molecular weight heparin. And they recommend low molecular weight heparin because of its better bioavailability, ease of use, and to avoid additional lab monitoring and minimizing staff exposure and limiting the use of PPE. These recommendations are based upon the findings of reduced mortality among patients who received the prophylaxis, 40% versus 64%. For critically ill patients, they also recommend to keep a high suspicion for pulmonary embolism in case of worsening oxygenation or hemodynamics and switching to therapeutic anticoagulation. For critically ill patients, increased dose of prophylaxis is also recommended, and this is based on expert opinion and varies across institutions. For non-critically ill patients, the dose of prophylaxis, standard dose of prophylaxis is recommended based on the existing guidelines. They also recommend the patients who are high risk or patients with obesity, the intermediate dose of 50% increased dose of low molecular weight heparin should be used. Patients who are discharged from the hospital often remain at increased risk for venous thromboembolism, and extended prophylaxis beyond discharge should also be considered for very high risk and for those who are considered to be low risk for bleeding. However, this should be considered on a case-by-case basis. In patients who have contraindication to pharmacologic prophylaxis, consistent application of intermittent pneumatic compression devices or ICDs with regular reassessment for conversion to pharmacologic prophylaxis is recommended. Additionally, for critically ill patients, it is reasonable to employ both prophylaxis pharmacologically and mechanically, as long as there is no contraindication to either modality. So in conclusion, there's high risk for both thrombosis and bleeding among patients with COVID-19. Elevated levels of D-dimer and fibrin degradation product are associated with high mortality. Standard dose thromboprophylaxis is recommended for all COVID-19 patients. Increased doses of prophylaxis for critically ill patients can be considered, and it is reasonable to use both mechanical and pharmacologic prophylaxis for critically ill patients. So this concludes my presentation on COVID-19 and thromboembolism, and I am open to questions and discussions. Thank you.
Dr. Batool, congratulations on that excellent presentation, and thank you for all of your outstanding efforts caring for patients during this pandemic. We'll now be moving over to the question and answer portion of the session. As a reminder, please submit questions through the Q&A feature at the bottom of your screen. The chat feature will not be monitored as well for questions. We've had a number of questions come in. This one I think would be most interesting to start with, and it's around case studies. The question is, could you share any case studies of real-world practical applications of pharmacological and or mechanical prophylaxis in prevention of VTE in COVID-19? Dr. Batool?
Hi, yeah, so I am just going to briefly describe two case reports that that came across. This one person who was 55-year-old gentleman without any significant past medical history, and who presented with fever and dry cough. Exam was consistent with decreased breath sounds, and room air oxygen level was 95%. And chest x-ray showed bilateral patchy infiltrates. On the lab data, his CRP, D-dimer were elevated. He was treated basically as, and COVID was done, which came back positive. So he was treated with, because he was not critically ill and he was stable hemodynamically, he was treated with antibiotics. And with progressive worsening, and on day 10, he started developing respiratory distress. His oxygen requirement went up. And at that point, the CT angiogram was done, which demonstrated bilateral pulmonary emboli. At that point, I think this case is from the time when we were still learning about the thrombotic episodes in the COVID population. And so the coagulation workup was done, and he was found to have elevated factor VIII and von Willebrand factor. Of note, he was on low molecular weight prophylaxis, just the standard dose all along. Then similarly, there was another patient, 42-year-old with no past medical history, who presented with chest pain and hemoptysis and shortness of breath. And his CT showed bilateral segmental pulmonary emboli. So if we look at these two patients, and if we do risk assessment approach for VTE, these patients do not fit that criteria. They were relatively stable. However, given this very high risk of VT among COVID people, universal strategy for venous thromboembolism is, that's the reason it's recommended rather than individual risk assessment. So if you just go by the risk assessment tools, then you may not consider those patients as high risk for VTE, whereas if they are COVID positive, this is a separate cohort and they should be considered very high risk for venous thromboembolism, and they should be given, depending on their risk. Some have recommended more than the step-up approach of low molecular weight heparin by giving 50% increased dose of low molecular weight heparin, and they use it twice a day for prophylaxis.
Thank you for sharing those case studies, Dr. Batool. A number of questions have come in looking or asking about some of the evidence that was presented. I'll try to summarize the questions into one. It looks like the questions are around that the studies that did not show a decrease in VTE rates with prophylaxis. The question is, were patients receiving combined modality prophylaxis in those studies or just pharmacological prophylaxis? Do you have any comments to share there, Dr. Batool?
So as far as I remember, they were only getting pharmacologic prophylaxis on a standard dose according to the regular standard recommendations.
Okay, great. Sticking with the theme of pharmacological for a minute here, a question that came in: are there any concerns with the use of heparin for hospitalized COVID patients? I know you just commented on that within your case studies. Do you have anything else to share there?
Yeah, so I think the heparin requires frequent monitoring of PTT, and some patients with COVID have baseline elevation in the activated thromboplastin time. So you cannot use that number to decide the therapeutic level of heparin. And also it requires frequent monitoring and staff exposure. So that's another reason to avoid the heparin. But if you have to use heparin, then you have to check the anti-10A levels to monitor the therapeutic level for heparin. And also some people have heparin resistance, which is considered if a person is requiring more than 35,000 units in a 24-hour, then it's considered a resistance. And that's also related to the acute phase reactants in the patient. So for those reasons, and also the heparin-induced thrombocytopenia is more common with heparin. So they recommend low molecular weight heparin as opposed to the traditional heparin.
Okay, great. A number of questions have come in around risk assessment. One question that I think summarizes several of them asks about the Caprini score or Caprini risk assessment or other types of risk assessments. I'll try to summarize it into one. Does the Caprini risk assessment tool apply to COVID critically ill patients, or is there another type of risk assessment that should be used instead?
So like I said before, that using those risk assessment approach may not be and also it's not recommended by the experts, and they have recommended to use a universal strategy for VTE prophylaxis rather than the risk assessment, because these patients are definitely at higher risk. So they should be giving the high risk prophylaxis.
Great. More questions around heparin. It seems to be a concern here for several people. One question asked about any increases in minor or major bleeding events with using higher doses of heparin in these critically ill patients. Another question was around their facility using increased doses across the board for COVID-19 patients. Do you have any concerns there, Dr. Batool, around this extra measure? Go ahead.
So, for if a patient is requiring very high dose of heparin, then there's a concern for heparin resistance, and should definitely move away from heparin and switch to a different treatment, or check the anti-10A level rather than just monitoring the PTT. So that would be something to that's recommended according. Again, I mean that it's such a evolving and emerging data, and we're learning every day a new thing on this COVID. So far the guidelines suggest that to stay with the low molecular weight heparin as much as possible, unless there's a contraindication, creatinine clearance, then you can move towards the heparin.
Very good. I'll give you a pause there for a moment. A lot of comments and questions came in thanking you for a great presentation. Also questions around the slides. I will say that this presentation is being recorded, and we will share the link to the presentation within a week's time. Many more questions coming in, Dr. Batool. We'll shift gears a little bit towards non-critically ill COVID patients and thinking about patients as they transition to home. This question is for non-critically ill patients, how do you manage mobility in isolation or in isolated patients?
It is. I know it's a tough, it's a tightrope. You have to, I mean, you can mobilize these patients as much as you can, but keeping the restrictions from exposing to other people. And in terms of extended thromboembolism, for people who are critically ill, they remain at very high risk for VTE even after discharge, and up to 6 weeks they remain at high risk. And it has been documented in studies that there's increased risk of VTE among people after they discharge from the ICU or after being critically ill. So there are recommendations about using anticoagulation beyond the hospital stay, but then you have to weigh the risk versus the benefits. People have increased risk of bleeding, fall. So for people who are minimal risk for bleeding, it's not unreasonable to extend the prophylaxis beyond hospital stay. But it has to be taken by case, and it's just, it has to be individualized.
That's probably the answer to this next question. I'll ask it anyway to make sure it's covered. With regards to discharge and extended prophylaxis, do you have any comments on how long, on average, patients should be treated with anticoagulation?
6 weeks is the time that they for 6 weeks, they are at risk for venous thromboembolism. And there was a study suggesting that most VTE, almost 60% VTE, develop within the 3 weeks after discharge. So this is something that if there's no contraindication and no concern for drug-drug interaction, then the direct oral anticoagulants are something that can be considered for short term.
Great. This question asks to expand on that a bit, asking about as hospitals speed up discharges to free up for ICU beds, what VTE prevention strategies should be done 7 to 14 days after discharge? Any additional comments to share there, Dr. Batool?
So, I mean, between the low molecular weight heparin and then the direct oral anticoagulants is much easier. But if there's any concern for drug-drug interaction with the DOACs, then you have to either use the low molecular weight or the Coumadin, but then frequent monitoring remains another concern.
Here's a very specific question from Dr. John in India. Can D-dimer / FDP levels dictate anticoagulation?
So they definitely dictate the acute, I mean, the acute phase reactants, and they dictate that increased risk for coagulation. And definitely, if you have someone with elevated D-dimer, this should be treated with prophylaxis unless there is a definite concern for a clot that you need therapeutic anticoagulation, because you again carry the risk for bleeding. And sometimes what happens among these patients that you are unable to image these patients because of their severity or because of the resources not available, or because patients are prone and you cannot do their ultrasound or get them to the scanner to do imaging. But if your pulmonary status is deteriorating, and if you have very high oxygen requirement, then definitely considering a therapeutic anticoagulation is something that if there's no contraindication.
Great. Another very specific question came in. Are we seeing more peripheral PE than central? And if so, why might this be?
Because I think it's a microcirculation and microthrombi that we have seen on the autopsy pictures. So seems like it's just microthrombi in the distal circulation that we are seeing more.
Very good. This question is about the age of patients. Does the age of your COVID-19 patients impact your choice of thromboprophylaxis?
I wouldn't. I don't think that the age. the only thing, if you're on a very extreme age and high risk for bleeding, you have to be careful with what modality of anticoagulation you are choosing. And if there's any concern for bleeding, then using mechanical prophylaxis versus the pharmacologic prophylaxis would be ideal for that scenario.
Great. This question's a bit different. I think thinking about the pandemic and isolation and cleanliness, this question is, our hospital reprocesses some single-use items, including compression sleeves. What's the best practice regarding cleaning and reusing equipment?
So I would defer this to the infection control of individual institution, because every institution has their own infection control policies. Definitely in this during these times, we are economical challenges and in shortage of supplies. It's possible that people can reprocess these things as long as they are cleared by the infection control of a particular institution. Because of even the N95 mask nowadays, we are just processing those after sterilizing those masks because of the global shortage of these supplies.
That's a helpful perspective. Thanks for sharing that. This question goes back to thinking about patients and their risk assessment. It's a couple sentences. I'll read it here to make sure that the message is clear. With all patients in general, the risk of DVT and PE, according to studies who are admitted to hospital, it's been shown to be high. Evidence has shown that using thromboembolism, whether it's mechanical or otherwise, has shown to help in hospital or with discharged patients. Does it not make it worse with patients in this particular group in isolation and COVID-19 patients who are on ventilators? Is the disease condition the real issue here, or is it a certain situation around their conditions like lack of movement, etc.? Is that clear, Dr. Batool?
Yeah, I think, I mean, there definitely there are independent risks associated with immobility, ICU admission, and severe sepsis. There's a sepsis-induced coagulopathy or a coagulation disorder. So, and people are immobilized for extended periods, so they're definitely putting them at risk. But COVID in itself activates the clotting cascade and puts an additional risk of VTE among that population. Does that answer your question?
I hope so. Another question came in here, and thank you again for all the great questions. If you have additional questions, please again use the Q&A feature at the bottom of the screen. This question states, how do you manage a patient on a heparin drip with high or low PTT/INR or imbalance levels?
So for heparin, again, COVID patients some patients have baseline elevated PTT. And if available, the anti-10A levels should be monitored on those patients to assess the therapeutic window for these patients, as opposed to increasing the dose of heparin, because they may not be, they may be resistant to heparin.
Great. Another question that came in, very specific question for you, Dr. Batool. Is there a linear or otherwise relationship between D-dimer or other markers and the prothrombotic state with regards to prophylaxis or prophylactic therapeutic intent?
Can you repeat that question?
Of course, of course. Is there a linear or otherwise relationship between D-dimer or other markers and the prothrombotic state with regards to prophylactic and therapeutic intent?
Definitely, the higher the D-dimer, the increase the risk of VTE. So there is definitely positive correlation. You can say it's a linear relation between the level of D-dimer and the risk for VTE, and that will definitely guide you in the direction of picking the prophylactic, whatever prophylaxis you want to choose, based off of those levels. And particularly, I mean, if you look at the ISTH guidelines, they recommend the thromboprophylaxis regardless of the D-dimer level for a COVID patient. They say they are high risk, so you shouldn't be waiting for these levels. You should just start the prophylaxis for these patients, because it's enough evidence to support that these patients are at higher risk for coagulation.
You may have just answered the next question that just came in. I'll ask it anyway in case you have anything to elaborate. Given the high risk of VTE and immobility in the COVID patients, should both pharma and mechanical be considered concomitantly during the acute hospitalization period?
It has been suggested that, and even in the guidelines, they say that for critically ill patients, you can use those two together, but there's no direct evidence in research that it has made a big difference. But it's not, as long as there's no contraindication for using the two together, or there's no contraindication for either of the modality, they can be considered.
Great. As a reminder, we are wrapping up here shortly. If you have any additional questions for Dr. Batool, please enter them into the Q&A feature at the bottom of the screen. And we'll also be sharing a recording of this presentation within a week's time. Dr. Batool, it appears that there's no additional questions at this time. That was quite a few that came in. We appreciate all of your answers. Do you have any concluding remarks before we end the session?
So speaking of that anticoagulation and then the post-discharge, the direct oral anticoagulation that patients can, it's ease of use, patient can take it orally. The only drawback is that most patients with COVID now, if they are on any new antiviral or any new trial, then just be mindful of that they could have some drug-drug interactions. So just be mindful of those drug interactions before prescribing those medications.
Excellent. Well, let me please reiterate my thanks and my congratulations on behalf of everyone for an excellent presentation and some nice answers to all of the questions. We've had numerous comments come in through both the chat as well as through the Q&A, thanking you for this excellent presentation. So this concludes our presentation today. Thank you for your attendance. Thank you, Dr. Batool, and please have a great rest of your day.
Thank you so much, Bill, for giving me this opportunity, and it was a pleasure working with you on this topic.
Excellent. Thank you, Dr. Batool. Bye-bye.
Bye.